Thank you very much. It's an honor to be here. And my role is to reinforce what Dr. Caterina so brilliantly presented. And so I have no conflicts to report. And again, following on Dr. Caterina, I am going to use examples from endometriosis, but everything that I'm going to be reinforcing is pertinent to female-specific and female-dominant chronic debilitating conditions. So endometriosis is a condition marked by the growth of endometrial-like tissue outside of the uterus, which responds to the cues of the menstrual cycle, building up and sloughing off and resulting in scarring and adhesions, but also associated with chronic pelvic pain, whether it's cyclic or acyclic, fatigue, infertility, depression, anxiety, and affects 20 million women across the globe. These symptoms, although highly prevalent and life-impacting, are not specific and are associated with other disorders. This is a common theme across female-specific and dominant conditions. And this results in a circuitous path to diagnosis that results in interactions with many organ-specific siloed evaluations and testing, and often specific to gynecologic conditions, as Dr. Caterina just so wonderfully summarized and reinforced for us. Often menstrual related symptoms are dismissed as being normal. There also is embarrassment, not only among patients for discussing menstruation and pelvic pain, but also among clinicians and healthcare providers. It is definitely still a stigmatized area that is impacting and results in, for example, for endometriosis, an average of 7 years from symptom onset to diagnosis. And again, this is not unique to these gynecologic conditions. These are similar durations of attempts for accurate diagnosis and treatment for autoimmune disorders and for other chronic overlapping pain conditions. For endometriosis, for example, women who are successfully diagnosed report that 2/3 of them have been misdiagnosed with other conditions attributed to their symptoms, and the median see 5 or more healthcare providers before that diagnosis. When we consider across the life course and this lengthy window of symptom onset in the search for a diagnosis, we also need to recognize that for most of those suffering from endometriosis, the symptoms emerge in adolescence and young adulthood. And so thinking about these critical windows of potential impact and vital areas for research, we also know that if we consider cumulative impacts across the life course, and considering here chronic pain, for example, that as symptoms develop in adolescence, we have these accumulating hits to health, wellness, and stability from school absences, impacted development of negative and maladaptive coping mechanisms, impacts on building social networks and social interactions. And then also thinking about alterations in career paths, job attainment that then has long-term economic impacts and access directly to medical insurance and healthcare. And so the accumulation across the life course has many points that need discovery and potential for great intervention and benefit for all who are not just female and experiencing these conditions, but those around them and society as a whole. This really can't be overstated. Now, when we think across the life course also, these are chronic symptom-associated conditions that end up having treatments that are often long-term exposures with side effects. And so hormone-dominant treatments result in vasovagal responses, bone mineral density impacts, androgenizing symptoms. And then also for those who are taking high-dose, long-term analgesics, such as NSAIDs and acetaminophen, opioid exposure, they also have multisystemic impacts on kidney, liver, stomach health, and other chronic impacts. And as Dr. Caterina also really nicely summarized, that a primary response to gynecologic associated conditions is often hysterectomy, bilateral saphendouphorectomy, resulting in surgical menopause, which we now have a growing body of understanding through life course studies and prospective studies are associated with earlier onset and higher incidence of cardiovascular disease, some associations with Alzheimer's disease and mental health. And so we can't ignore the multi-systemic long-term impacts of these conditions. And as these coexisting conditions accumulate with the accumulated side effects, we also need to think about our siloed approach to women's health funding and medical care, noting that for endometriosis, and again, this is just an example of female-specific and dominant conditions, there are coexisting interactions with virtually every organ system and area of medical care, gastroenterologic, mental health, immunologic, oncologic, cardiovascular. And so we need to be facilitating a view of research and clinical care specific to whole women with gynecologic health as an integral part of that view. For this research, we need a lot of information and data. We're not just interested in the surgical imaging phenotype of endometriosis itself, but also the biomarker, genetic, and omic evaluations, interaction with these other conditions, environmental and behavioral exposures. However, for those needs, they require clinical and phenotypic data from a large number of diverse women and tied to these many critical life course windows. This information just doesn't exist in biobanks and electronic medical records as a standard of care and routine documentation. They do exist in the long-standing prospective cohorts, and many of those cohorts have been supported, for example, through NCIs. In the 70s and 80s into the early 90s, there was the launch and great infrastructure funding support for cohorts, so many of which exist now, more than 60, that there's actually a lot of funding and infrastructure around harmonizing and collaboration in a cohort consortium initiative. This has been revolutionizing information for healthcare. However, within these longstanding cohorts, most do not include data on endometriosis, more broadly on gynecologic conditions, and very few have pain measurements or reporting or definitions included across the life course. And so while those resources largely exist, they are failing many of these female-specific and dominant condition evaluations. Further, we know that there is, again, revolutionizing data and information being produced and collected and researched across these different biomolecular and genetic pathways of gene and protein expression, and ultimately the proteome and metabolome, those phenotypic expressions, how they interact with the environment, and large normative and disease-specific databases have been built and are being added to. Unfortunately, when we look at ENCODE, NIH roadmap, GTEx, HapMap, they largely do not include the tissues and data specific to female-specific conditions. The endometrium is largely not included. Also, those tissues and biomarkers and epigenetic data that is included for other organ systems often ignores menstrual cyclicity, menopausal status. And so these are huge holes in what is perceived to be widely available, but is holding back our field. Further, if we look specifically at issues around funding, this is a really informative graph created by Ron Chandler at Michigan State that graphs on the y-axis the NIH funding dollars in 2019 by the disability adjusted life years. And as you'll see, this black line above this line are those conditions that are receiving funding that surpasses their DALY calculation. Below this are those conditions that are receiving funding well below their DALY estimation. And so as we can see in the darker blue, the male dominant conditions, there is only one that actually falls below that line, and that is liver cancer. However, for female dominant conditions, the majority of conditions actually fall below that line, and those above the line are mostly cancer-related conditions. And so this has impacts not only on the ability for discovery that has been discussed, throughout today, but also thinking about the pipeline of who gets pulled into and retained in research and exciting initiatives. What is the draw for multidisciplinary and multi-institution initiatives? And so these are things that need to be directly addressed. I will reiterate Dr. Caterino's needs for advancement of chronic disease research, again, listing specifically a recommendation for a National Institute on Women's Health that addressing female-specific and female-dominant disorders across the life course is infinitely beneficial, and that collaboration among institutes, all of which have interest in women's health, building female-specific foundational normative and chronic condition databases, as well as designing trials and studies directly related to female-specific symptoms. And I thank you for your time.